All right, so you're all here to learn about menopause. So we're going to go through menopause, and I suspect the female members of your group will see more of this, but you guys, it's very important for you to know about this as well. So in terms of looking at all of this, these are very important definitions. So menopause is just the last period. So when a woman stops having her periods at average age 51, that's menopause. But you'll see there that sometimes things go a bit astray, and premature menopause is when that last period happens before 40 years. Now, they're a very, very special group. It's about 1 in 1,000, so they're not that rare. You will come across one or two, especially the females. Those women are very important because they are lacking estrogen for about 10 years, where they would have been covered by it. So they really need specialist management. Perimenopause is a very difficult time, and that is when hormones are secreted in a very erratic fashion. So that's a much more difficult time to manage compared to just menopause itself. So hormone secretion is very erratic. The pituitary is desperately trying to do the right thing that it has done throughout its reproductive life, get enough estradiol out of the ovaries, but it just can't do it anymore. So that's the trouble with perimenopause. So you'll see changes in the pattern of menstruation. There'll be erratic hormone secretion, and they'll often have symptoms. So often they'll come typically around the mid-40s. They'll have flushes, they'll have sweats, they won't be sleeping as well, they might be very cranky, irritable. So is anyone in the room about in their 40s or so? No, you're all too young, you don't have to answer that. And this, it says it can last 2 to 7 years. It can actually last up to 11 years. So before that last menopause period at 51, they can be doing this all throughout their 40s, which is, you know, a lot to go through when they don't really know what's happening. They might be normal one day, next month they might feel like they're menopausal. So it's very confronting for some women. And because periods will sort of happen 3 months, 6 months, 9 months, and then one out of the blue, it's often hard for women to remember when that last period was. So we call the postmenopausal time when they haven't had a period for 12 months. So this is a very important slide because really there's a 20-20-20 rule which you can look at. So 20% of women will get severe symptoms, and they're the women most likely to present for help, so that they will get hundreds or thousands of flushes a week, they'll get drenching night sweats, and they'll have difficulty sleeping. So that their quality of life is really being eroded. 20% have no symptoms, so that's a shame in a way because you won't see them and they won't present for their blood pressure check, their pap smear, their mammogram, all that sort of stuff. So a little bit of a missed opportunity. You'll see that 20% of women also have symptoms which will last for 5 years. So some women will come to you at 50, at 60, and some will still come at 70 years and say, I've still got menopausal symptoms. So don't disbelieve them, some will actually have that happening. The rest of the women will have a combination of all of the other things that you were enjoying up there. So 80% of women will have some symptoms, and the typical symptom is flushes and sweats. And really you can't start to understand until you've spoken to a lot of these women how debilitating the sweats at night can be. They can drench their sheets. This is a story I told the lady that I would tell people about, but one woman had to throw out her couch because she sweated through onto her couch so much. And the worst thing was the people from the opportunity shops wouldn't even take the couch. It was so soiled just from this physiological sweating, which was remarkable. So flushes and night sweats are very prevalent. Sleep disturbance. I think a lot of menopause is about sleep disturbance. So if the women actually slept, they'd be able to manage their symptoms a lot better. But because they're tossing and turning and can't sleep, that's very disruptive. Vaginal dryness is very important, and they might be too embarrassed to tell you, especially the male members. So ask them, just say, is there any painful intercourse? Do you have vaginal dryness? Because you can do things easily for those symptoms. These other symptoms are very important. That's formication. It's a feeling of ants crawling under the skin. That can be debilitating. It can be associated with restless legs as well. Joint aches and pains, some will come and you'll think, this lady's got a florid arthritis, but it's actually just estrogen levels dropping down, feeling these joint aches and pains. So you might think, God, she's got some atypical rheumatoid arthritis. Just think if it's around 50, might be menopause, and they'll often do well with some HRT, so please remember that. Difficulty concentrating, and that might be sleep disturbance or the estrogen levels going down. Irritability, some are just really, really cranky, and that might be the fluctuations or the sleep disturbance. Some get very anxious and some will get depressed. So the drop in estrogen levels can be enough to do that. So in terms of what estrogen was doing, estrogen was circulating throughout their reproductive life. And you know when you do a blood test for estradiol, it's sort of got those levels. Well, if you look at the levels, typically if you're having normal periods, your reproductive age, you're not breastfeeding or on the pill or have polycystic, so you're a normal woman, your estrogen will go from about 150, spike up to 1500 mid-cycle and then bump down again. On average, that estradiol level will be about 400 throughout the cycle. After menopause, if you do a very sensitive assay of estradiol, it's 20. So a seventh or so of what they were at lowest and a 20th of their average level. And that's a lot for women to handle when they've been used to this cyclical estradiol production. So some will definitely come with low mood. Don't dismiss them. They hate being told, oh, you're just depressed. Some will actually do very well on some hormone therapy. So really be aware of those women. So really what we're trying to do is make sure it's menopause. So if they come with atypical symptoms, for example, the flushes and sweats are the body up. It shouldn't be the upper half of the body, it shouldn't be the whole body. If they come with an atypical story, if they come with things like diarrhea or something like that, then think something else. But you do need to think if they're overwhelmingly fatigued, check their iron stores, check their thyroid, check a fasting blood glucose. If they do have really atypical joint symptoms and they've got swelling or tenderness or morning stiffness, then look at rheumatological causes. Some will be depressed at this point, so you sort of go down the menopause thing, but some will actually be depressed. We know depression is very common, especially in women, so you've got to just work around that because women hate being told you're depressed and here's an antidepressant. They don't like that at all. Thyroid disease is very common in women and can come out over this time. So look at their TSH, and it's a great time to say, well, let's do your blood pressure. Are you up to date for a pap smear? Do you need a mammogram? Shall we do your cholesterol? And some around the time of menopause will develop essential hypertension, and some their lipids will start to go up as well. So it's a great time to check all of that. So these very easy. The management options look easy. It's on a beautiful slide there, but there's a lot to all of this. Education is the first thing, and women will come to you with a whole lot of stuff from Dr. Google or the internet or whatever, or what Joyce next door is having. So they've got a lot of preconceived ideas, and your job is to actually say, well, hang on, that might be so, but these are the facts, and let's make a decision that's best for you and best for your health. Lifestyle is very important as well. With diet, you can reduce hot flushes by looking at spicy foods, reducing alcohol, etc. Exercise is very important. Those who don't exercise as much do get an earlier menopause, and they get more flushes and sweats. So just talk to them about exercise. Smoking, smokers have an earlier menopause too, and they're at risk of a premature menopause. So that's another good reason to say, hang on, let's kick the smoking. And stress management as well. So they're all stressed, they're all tired, they've often got teenage kids or kids in their 20s. They've probably got ageing parents with those issues. So everyone's stressed, but they also need to try and manage it. HRT definitely has a role at this time for some women, so you need to be aware of some products at least and be able to guide women with regard to that. A lot are taking complementary therapies. Almost all of the women who present to me around the time of menopause will be on at least something. So there's a lot of stuff being used, so just talk to them. Often I'll say, are you on any medications? Oh no. Well, are you on glucosamine? Oh yes. Are you on krill oil? Oh yes. I'm on all these other things. So they're important because they can all interact. And non-hormonal therapies, some will not be able to take HRT if they've had breast cancer, if they've had a clot in the leg or lung. So you need to be aware there's other options out there as well. So HRT absolutely works. So it does work if they're having flushes, sweats, vaginal dryness, all the rest of it, they will get some benefit from HRT. It's not recommended for the prevention of disease, and there were a lot of studies in the late 90s and 2000s looking at whether HRT could prevent heart disease or stop heart disease in its tracks if you already had heart disease. So the current stance is we don't recommend it for disease prevention, but premature menopause is a very, very different scenario, and we would recommend HRT or some form of hormones up until the age of natural menopause, which is about 50. So if they present at 30 with menopause, they should be covered with something. It could be a pill, the oral contraceptive pill, but some form of estrogen until they're about 50. You do need to weigh up the benefits and risks for each individual, and I sort of do that. I sort of go through the whole thing. This is menopause, this is your estrogen, this is your symptoms, these are the options. And often you'll tie it in with something like they might have a strong family history of osteoporosis, they might have had osteopenia themselves, so you look at all of that stuff as well. So the types of HRT, estrogen alone treatment is only if they've had a hysterectomy. So if they have a womb, they can't just have estrogen alone. So that's very important. They will need estrogen and a progestogen if they have their womb or uterus intact. And really what they did in the 60s or so, they gave women big doses of estrogen without progestogen, and they found in the 70s that they were having an increased incidence of endometrial cancer. So we realise now that the progestogen is only necessary in those with a womb for endometrial protection. There is a lot of interest in women taking progesterone for other reasons, and you would have seen books about it, or take progesterone, and people actually do the lecture circuit saying, you're not on your progesterone, you need it for this, that and the other. The current evidence is such that you only really need it for endometrial protection, okay? If women have just finished having periods, maybe within the last year, last 6 months or whatever, their womb lining is such that they will tend to bleed. So you need to give them what's called a cyclical regimen of HRT, and that will be estrogen throughout the month, usually, and progestogen for only a small amount of the month, probably up to 2 weeks, and then they will get a withdrawal bleed. So there are products designed with that in mind. And if you try and put them on a continuous regimen, which is just estrogen and progesterone throughout the month, that they may have bleeding issues. So if they're very early to menopause, just stop bleeding within the last year or so. I'd always give them a light scheduled bleed with one of those products. In terms of the pill, you can use the low dose pill in women sort of in their mid to late 40s without any problems. So I do see that at some point women come to me and say, I was told I couldn't take the pill because I was in my 40s, but you can definitely do that. If they don't have significant cardiovascular risk factors, if they're not smokers, if they haven't had a clot in the leg or lung. Tibolone is a very unique compound, and that's a synthetic compound, and I think we're going to go through that in more detail, but it's quite different from other forms of HRT, but definitely an option. When we're giving HRT, we do it in different ways. And traditionally, we used to give a lot of oral HRT, and because of these big studies, you know, the WHI study where they were looking at preventing heart disease in women, these studies have typically used products like conjugated equine estrogens, which is Premarin, and Provera. So I think because of those studies, and because we know when you're taking oral HRT, it goes through the liver, it induces the production of various proteins, and those proteins have been found to be a marker of cardiovascular risk. So more and more we're going away from using oral forms of estrogen or HRT, but they are very good forms of HRT still, and in a given individual they might be a great option. So don't be scared away from it, but we're sort of veering away from it as a society. Transdermal means of HRT, we're favouring those more because it's a lower dose, goes straight through the bloodstream. It's avoiding the liver. And it's probably better tolerated. With oral HRT, they can have some breast tenderness, breast fullness, fluid retention and all that sort of stuff. Vaginal estrogen is an extremely good way of giving estrogen if their symptoms are predominantly vaginal, and there's only a very small spillover into the blood from vaginal estrogen. So if they're worried about taking hormones and getting big hormone levels in their blood, vaginal estrogen is really mostly locally absorbed. Intrauterine progestogen in the form of Mirena has been a great introduction, a great way of protecting the endometrium. They can have that in place for 5 years, some will say up to 7 years, and then you can easily give estrogen systemically without any problem, and mostly they won't bleed. So that's one of my big things that I try and do around the time of perimenopause. Often they'll come with flooding or bleeding abnormalities or frequent bleeding. A Mirena's in, that settles the womb and the bleeding, and then you can easily treat their symptoms with topical or transdermal estrogen. So that's been a great development, having that option around this time. So when we're looking at different dosage of estrogens, I'll draw your attention to the bottom two websites or web pages, because they are a brilliant source of information with regard to this. So you'll see that there's differing doses in terms of the conjugated equine estrogens. A low dose is considered 0.3 milligrams, a usual dose is 0.625, and when you're looking at pure estradiol, 0.5 milligrams is the lowest. We do prefer the lowest dose that will control their symptoms, and that means they're just not being exposed to as much estrogen. And we're looking, you can use the estradiol gel as well, the sachet form of gel that you can rub in, or there's the patch, which is typically twice a week, although there are some patches which are once a week. So that Australasian Menopause Society information sheet is brilliant. It goes through what products are on the PBS, what are not on the PBS, what is a low dose, what is a medium dose, and how to combine the products and what products there are available. So if you haven't seen that, print it out. It's a brilliant guide in terms of what progestogen dose do I need with a particular estrogen and what have you. The other one is the National Prescriber Service. That's pretty good as well, and it's a little bit briefer, but I can't recommend those more. They're really good. So in terms of the HRT products, there's been a big change in the last 10 years or more because of that Women's Health Initiative or the WHI study. A lot of companies backed back, and I suppose we had the GFC in the middle here, so companies had to be commercially viable as well. So a lot of the companies became, I suppose, a little bit wary of HRT and the risks of breast cancer and all that sort of stuff. They withdrew a whole lot of products, and similarly, a lot of products were removed from the PBS. So that will be an issue for those of your clients or patients who just can't afford those products, and there's some good products out there. So on the PBS, we have a variety of estrogens still available. The patches are there, the Progonova, the estradiol is there. The progestogens, unfortunately, we're limited to Provera and Primolute. So in terms of tablet form, the only combination product, which is a patch, is the Astalis Continuous or Sequi. So we're quite limited there. Not on the PBS, some will be able to afford it. Unfortunately, Tibolone has never been on the PBS, and some women will be great on that product. You'll see most of the combination estradiol and progestogen products are not on the PBS, unfortunately. Angelique's a very novel compound. It has a novel progestogen dysperenone, and it may be good for women, for example, who have extra things such as some scalp hair loss, because that blocks the testosterone receptor as one of its functions, and it also will probably help them lose 1 or 2 kilos and will be good for their blood pressure. So that's another option that you might not be as familiar with. So what are we getting in terms of the benefits of HRT? Well, you probably know this, but hot flush frequency will decrease by about 77% and severity by 87%. So in terms of looking at placebo versus treatment studies, placebo effect, you'll get about a 30% improvement anyway. That's just known from studies. But with HRT, you're getting a much higher than placebo effect. We know that you'll reduce the osteoporotic fracture risk, and that was a good thing that came out of that Women's Health Initiative study. Before that, we really didn't have a big study showing that there was fracture prevention data. So it does decrease the incidence of all osteoporosis-related fractures, and it really should be the first line that you look at for women who are less than 60, considering the other options for osteoporosis have their limitations as well. So always think of HRT. It will just buy them a little time, so later on when they're after 60 they might be able to have a look at the other options as well. Certainly in women with premature menopause, we would definitely support use of HRT. There's a reduction in colorectal cancer risk that came out of the WHI study, so that might be important for those with a strong family history of colorectal cancer. And we think there's also possible cardioprotection in women who start less than 60. So if you go through life, have menopause, start HRT from 65, we don't think there's going to be cardiac protection. So there's this concept of a window of opportunity. If you start HRT around the time of menopause, you're probably going to get protection from various things, especially with cardiovascular disease. So urogenital atrophy. Now the bottom point is what I'm going to highlight first, that vaginal candidiasis is very rare in the postmenopausal woman. So they will think it's thrush, they will come to you and they say, I keep getting thrush, but if they're around the time of menopause, just do your light bulb moment and think it's got to be estradiol deficiency. So I would treat for estrogen deficiency first, and then I would, and it will take 6 to 8 weeks of good twice weekly vaginal estrogen for the vaginal symptoms to improve. If you think it's thrush and you do a smear or whatever, or a swab and it's thrush, it's thrush. But think first in a menopausal woman that it's probably going to be vaginal dryness. You don't need progestogen with the vaginal estrogen. There is a tiny spillover into the blood, but you don't need a progesterone at the same time. And systemic HRT will give relief eventually, but often you'll need to start them on systemic HRT and vaginal estrogen and stop the vaginal estrogen down the track. It does take about 2 months to sort of kick in. So just remember the vaginal candidiasis being pretty rare. So cardiovascular disease, we've talked about this window of opportunity. If you start HRT within the first 7 to 10 years of menopause, we think that that's where you're going to get a potential cardiac benefit. Remember in the WHI study, their average age was 63 years and they were aged up to 79 years and they weren't having symptoms. So they are very far removed from your typical menopausal woman who was 50-ish with symptoms, all right? So that's where the cardiovascular risk, it was actually those older women who tended to be at more risk. There is an increased risk of cardiovascular disease if they start after 60, and also if they have pre-existing heart disease. But again, it's mostly related to those older women. These are the things that women will worry about, and no woman wants to take HRT. They just don't want it because of the media and because of breast cancer is very prevalent in the media, and they know that there's a link there. So breast cancer will be probably the biggest thing that you'll have to get through as a hurdle. So it's important to be very aware of the facts with regard to HRT. Cerebrovascular disease, potential adverse effect, and VTE is another adverse effect, which they probably won't come worrying about, but you need to tell them. So in terms of the breast cancer risk in a young woman around 50, that's still young, you're not old till you get to 88, no one in the room's 88, I know that. When you're around that age, we think you can take HRT for about 4 to 5 years without having an increase in breast cancer risk. So that increased risk happens after about 5 years of use, and that was from the WHI study where they used it for 5 years, their breast cancer risk was the same, and it went slightly up above the normal curve. The interesting thing that wasn't highlighted in that study, the women who had had a hysterectomy and were on Premarin alone, they used HRT in the form of Premarin for 7 years and actually had a reduction in breast cancer risk. So we think the progestogen in that study in particular was altering their breast cancer risk, or maybe the combination or whatever. So estrogen only, I'm a lot happier with, in terms of I can say to a woman, if you've had your womb out, you can have estrogen alone, well, we think from the studies, for 7 years without increasing your risk and actually having a reduction in risk. So that's important to know. You do need to do your annual breast examination. There's a lot of controversy about the mammogram screening program. Does it reduce breast cancer deaths and all of it? There's a lot of controversy. The bottom line is the government have said we do our mammograms every 2 years. You encourage your patients to have their mammograms every 2 years unless told otherwise. So cardiovascular disease, we shouldn't initiate HRT to secondarily prevent cardiovascular disease. You will have patients who have flushes and sweats and who have cardiovascular disease. It's just going to happen. Cardiovascular disease is so prevalent and symptoms are prevalent. So that's often you might need specialist guidance there. All right, so just remember that. There may be a place for using transdermal HRT, and that would always be my first port of call if they did have symptoms and cardiovascular disease, and I thought HRT was their best option. We're not using HRT for primary prevention of cardiovascular disease, and we've talked about that window of opportunity already. Cerebrovascular disease just isn't that common in women less than 60. So there's not a huge impact of HRT because there's not a lot of cerebrovascular disease, but there may be a small increase in women over 60 years. Tibolone, for example, there'll be a slight increase in stroke risk from the mid-60s on, and that's study-based. So when you're looking at VTE, there's an age-related risk of clots in the leg or lung, and you know that. So at 50, the typical menopausal age, it'll be about 1 in 10,000 women, their absolute risk. So you can safely say it's very low, but at 60 it goes up to 1 in 1,000 and it exponentially goes up after that. You know about the additional risk factors, so immobility, long-haul flights, surgery, and hereditary thrombophilias are not that uncommon. So I always ask menopausal women, if I'm looking at HRT, is there a family history of clots in the leg or lung? And often you need to direct that question rather than asking them to just say a family history. Smoking, obesity, they're going to increase their risk as well. So that risk with HRT is a 4-fold risk in the first year, and it's a 2-fold ongoing risk with HRT. So you'd make that a 2 in 10,000 risk. So it's not huge in terms of your clot risk. We think it's a low risk with estrogen alone, and the studies with transdermal forms of HRT do not suggest an increased risk at all, and there's no increased risk with tibolone. And when you look at the studies, tibolone actually favourably affects fibrinolytic and clotting markers. So that can be an option if you're worried about VTE risk. So in terms of endometrial cancer, there is no increased risk on combined HRT. We talked about the need for progesterone if they have a womb. There's a well-documented increase. If you give estrogen alone, they have a womb, they will be at risk of endometrial hyperplasia and then neoplasia down the track. When you're reviewing treatment, I give them 3 months. Before that, I think is too early. They'll need to know, does it work? They need to sort of settle into it and get their levels at an equilibrium. And you will also, that time will be enough to get bleeding issues sorted out, breast tenderness, fluid retention, and give them a chance to sleep and sort of reset their life. So 3 months to me is the best time to review. I say, do you have breast tenderness? I go through all of those things I've just mentioned. Are you managing it? Some just have a lot of irritation at the patch site, for example, and you need to make sure they're rotating it and all that sort of stuff. Then you review them annually or 6 monthly. Most of the scripts will last for 6 months, so I think that's a great opportunity. Get them back, make sure they've done everything we need to do. Assess, do they need it anymore? And probably they're going to need it for about 1 to 2 years, and then you will try and wean them off. The studies don't support any difference between cold turkey stopping and weaning it off, but I do a lot of this with these women, and really they do better with weaning it off. So if they're on the patch, you increase the frequency between the patches. You can cut the patches. Some pharmacists get upset about that, but you could have one patch Monday, half a patch Thursday. So you do it in a very gradual, gentle, considered way, and then I think they're less likely to have ongoing symptoms. You look at their screening tests, so they have their pap smear, mammogram, cholesterol, etc., and try and get them onto the lowest dose. So if you see someone, they've been on HRT for a long time, you think, do they need this big dose anymore? Try and just wean it down or change them. And often they'll come to me and they've been on something like Premarin and Provera, and I'll say, well, hang on, let's try a patch now, because different way of doing it. You've been on that HRT for a while, and that can obviously be a good change as well. The side effects we've sort of touched on already. Bleeding can be an issue, especially in that first 3 months. So if you tell them that and they have the expectation, they won't be as worried when it happens. Breast tenderness can be a real issue as well, and some will actually increase in breast size. So I've heard that many a time now. There are progestogenic side effects, and the progestogens we have are not fantastic in terms of the side effects in some women. Acne is a problem for some women, especially on Primalute, and some will get mood changes, fluid retention, and they're not happy. That's why the Mirena is a great option, because there are very few women who've had systemic side effects from Mirena. It's in where it needs to be, and really the systemic side effects should be just from the estrogens. And poor symptom control. Some women just don't get enough symptom control. I'm being attacked here. They will say, I'm gaining weight because of my HRT. We think that there are changes around metabolic rate at the time of menopause, and it's been well documented that they will gain weight around the time of menopause. Those who don't gain weight around menopause, there's been studies looking at this, will be exercising about an hour a day. Now, are any of you exercising about an hour a day? Because I'm not exercising about, although I could have ran the whole way to get here. So those are the women who don't gain weight. So you need to tell them, actually, it's either age, it's menopause, it's probably not the HRT, all right? They will all say that. Don't want to start this, I'm going to gain weight. So that's the two things they're worried about. So you've got to get through those barriers. I'm going to gain weight, and I'm going to get breast cancer. So you need to sit back and say, I knew you were going to say that, and I'm going to deal with it. Okay, all good. So Liviol or Tibolone is a very different compound. It's more a progestogen, but it splits into 3 isomers. It acts like an estrogen, it acts like a progesterone, and it also acts weakly like testosterone. So it's a synthetic steroid. The estrogenic effects, it's great for the bones. Studies have confirmed that even in much older women, even at half a dose. It's great for vaginal dryness as well, and for flushes and sweats, but it doesn't have the estrogenic effects on the breast. When you look at the studies, Tibolone at the sort of scientific level inhibits breast cancer cell growth. They did a study called Liberate, trying to see if they would get less breast cancer recurrence. So women with breast cancer and terrible menopausal symptoms, they gave half of them Tibolone and half of them placebo, hoping that the Tibolone they'd get less breast cancer recurrence. Unfortunately, they got more breast cancer recurrence. So even though at the cell level it's inhibiting breast cancer growth, there is a breast cancer risk associated with Tibolone, and it's probably less than it is with the other forms of HRT. The androgenic effects can be beneficial for those women, and many women will come to you. They might not come to the guys as much and say, my libido is terrible, it's causing a stress on our relationship, and I'm distressed about it. So if they need HRT, and if they're a year or more after menopause, Tibolone could be a good option. I've found with Tibolone that some women will take 2 to 3 months before it sort of kicks in. So tell them not to ditch it before that. I've been quite surprised. They've been on it for quite a while and then suddenly seems to work. It does reduce the risk of fractures. They have minimal breast tenderness as well, no increase in VTE risk. There is an increased risk of stroke probably from the mid-60s, and that's study-based. And we don't use this in perimenopausal women who are bleeding because they'll just have erratic bleeding. So you usually wait 1 to 2 years after that last period. So in terms of HRT, we use the lowest effective dose. We assess the benefits and risks annually. We decrease the dose or cease every few years to assess if they need it. And some women you will get, even at 70, saying, I want my HRT, you're giving me my HRT. All right, some are on it, they feel great, their quality of life is great. So you need to think, are they safe on it? Do they really need it? And do I need to refer to someone else to get another opinion? All right, so you will all get those women who just want to be on their HRT. And some women have ongoing symptoms, and I've certainly seen them in their 70s, and I try and reduce it, try and give the lowest dose of transdermal HRT, and they're still getting symptoms. So they are out there. Now, this is a great slide, and you can even show patients if you're keen. You can download this as a PowerPoint slide from the internet. The US Endocrine Society said, hang on, there are lots of troubles with HRT studies, in particular the WHI study, because it looked at those much older women as well. And what they did was they got from all of the different studies, they looked at those younger women, so 50 to 59 years or within 10 years of menopause, and they looked at the studies' benefits and risks and came up with this data. So in terms of hot flushes, so in this slide, the black lines are estrogen only, and the white bars with the black line are estrogen and progestogen. So you can see, as just a once off, this is comparing the benefits of HRT to the risks. And you can see they're getting benefits. They're far overwhelming the small blip in the risks. So the flushes are better, the vaginal atrophy much better. So that's an easy way to say, well, hang on, they're your risks, and that's your improvement. And this next slide is a blow up of the lower half of that, okay? So this is the risks in terms of benefits favoured on the right-hand side of the slide and risks on the left-hand side. So remember, the black bar is estrogen only. So have a look at this when you've got a chance. I know you're very busy people, but if you've got a chance at some point, have a look, because there's some interesting stuff here. So both estrogen and estrogen progestogen, they're getting less fractures, so there's a benefit for their fractures. There's also a benefit in terms of diabetes incidence. So that's something that we really wouldn't expect. I don't know why that is, but it's fascinating, isn't it? Also for overall mortality. So those women, these younger women around menopause who are taking HRT are dying less. So again, I don't know what that's all about. Breast cancer, you'll see that the combined HRT is giving them a risk on the left hand of the slide, but that's after the 4 or 5 years that we discussed, okay? In terms of other things, their heart disease, they're getting a benefit on both forms of the HRT. Endometrial cancer, they're getting a benefit on the combined. And really the main risk, when you see at the lower part of the slide, the venothrombotic episodes, the stroke, minimally so, and the main risk is cholecystitis, which is very interesting because I've never seen a woman come to me on HRT who's got cholecystitis from it. So that's a great thing to consider and to show them and say, look, this is your overall risks here. But they'll probably focus on the breast cancer thing, but you'll be well armed to talk to them. So if women have had breast cancer and definitely can't have HRT, or if they've had a clot in the leg or lung or a stroke or whatever, and you will see these women and they will have symptoms, these are the other options. And the Australasian Menopause Society makes a great information leaflet that goes through all the different non-hormonal options for treatment of menopausal symptoms. And there is also some great stuff on the Jean Hale's website as well. So the SNRIs, so typically I will attack first with venlafaxine, and I won't use that lower dose. I'll typically go for 75 milligrams. They will get about a 60% reduction in vasomotor symptoms with venlafaxine. And they'll usually, and if they're a little bit depressed, that'll benefit them as well. Some will paradoxically get flushes, and I've seen a few women who've been on this and they have flushes, and I take them off and the flushes are actually better. The SSRIs, so they are also a good option. There's lots of studies now suggesting they will benefit. Now, we need to avoid those particular agents, the paroxetine, fluoxetine and sertraline, in women who are taking tamoxifen, because they will inactivate the active metabolite of tamoxifen. So just remember that as a flag. So just look at the other options, such as citalopram, and that will be a good option as well. Gabapentin is a great option. You start very low, 100 milligrams or so a day, gradually build it up. They can have 300 milligrams 3 times a day, and that can be a great option for women with vasomotor symptoms. And clonidine is also a more older-fashioned blood pressure treatment, but that can be quite beneficial as well. Some will get a dry mouth, but usually, and if they've got blood pressure issues, that might act synergistically for it. So I've had women do well on all of those options, which is great. And it's the ones who don't do great on those options when they've had breast cancer that really you'll be struggling with. And if you're struggling, you just refer them off, all right? It's as easy as that, because someone out there will know. Testosterone is very controversial. There's no clear definition of female androgen deficiency. And there are a lot of difficulties with how to measure testosterone. So there are a number of labs that do it well, and they'll typically offer a sensitive testosterone assay. Some labs do not do it well. So you ask for a sensitive total testosterone, the SHBG, which is the protein which binds it very tightly, and that combination will give you the calculated or active free testosterone, which we think is the active moiety. Some women will come to you on a whole lot of stuff, including testosterone. There is no approved product for testosterone use in women at all in Australia, and there are very few worldwide. We don't have many options. The Androfem cream is a 1% testosterone cream. They apply it daily to their thigh, and you look at blood levels 3 weeks after they start treatment. And we're aiming to put levels. So this is what testosterone does in women. It's at a peak at about 20, falls down with age, and we don't know why this happens. Hits a bottom at 65, and it's halved by about 40. So there's no physiological reason that testosterone does that in women. It might be evolutionary, who knows what it's all about. And what we aim to do is, if we're giving them testosterone treatment, aim to put them back to what they were at 20. And that level is typically 0.9 to 2.5 nanomoles per litre, depending on the lab and the assay. A male level is 10 to 20 times higher. That we're never looking to go above that range, and we're never looking to treat at male levels. And we're also not using the male products. So some will come to you and say, I want this patch, or I want that underarm deodorant testosterone thing. You say, well, look, there are no products, and the experts have considered that this is really the best option. Herbal medicines, you will get these women, they will come to you. There's a lot of herbs out there. There aren't many randomised controlled studies, unfortunately, and there are small numbers and short duration, and there's a lot of people pushing particular things really for monetary gain. Women may be self-prescribing, or sometimes they'll get it from practitioners. You need a trained and good naturopath. It's like you need a trained and good doctor who knows their area. You need a trained, and some naturopaths are absolutely brilliant in this area. Black cohosh is probably their best bet if they're having vasomotor symptoms. They use it a lot in Europe, and particularly Germany. We only really have 6 months of safety data, and there were a few concerns that black cohosh could cause serious liver abnormalities, and some women have needed liver transplantation. When they looked at the data, they were not convinced it was related to the remifenums, but just you need to keep that in mind. Very rare, but there's a potential for liver issues. It can be combined with St John's wort, and you need to just be careful about drug interaction. So always just go through, are you on any supplements such as St John's wort, vitamin D, whatever, glucosamine? Just always ask them. I know you've got a very limited time, but just spit it out, and hopefully they'll spit it back. Phytoestrogens are plant foods that actually act either weakly or strongly at the estrogen receptor, and they're typically found in a sort of healthy Asian type diet. Japanese women, for example, don't get flushes and sweats as much. They get this sort of shoulder girdle aching and pains, and we're wondering if their phytoestrogen rich diet is protecting them somewhat, and it probably is. So things like soy, linseed grains, seeds, etc. Possible small effect on flushes, and we think that if they're going to get a benefit, don't just take it from a supplement, just incorporate it in your diet and you'll probably do better. And we think it's also beneficial for cardiovascular health. Bioidentical treatment, this is really being very pervasively marketed at the moment. They say that this is the way to get hormones naturally, and women really buy it. And it's quite expensive. It can be $60 or more per month. So it's combinations of hormones, usually in a trochet, which is a lozenge that they dissolve in the corner of their mouth. They're saying that it avoids first pass metabolism because it's going straight through the buccal mucosa and not going through the liver. I do think some is swallowed, so you need to be aware of that. And some are given by cream. So you would have seen progesterone creams and all the sorts of things. They will typically have not only one estrogen, but they'll often have biest or triest. Have you heard of those? So two types of estrogen, estradiol and estriol, and sometimes estrone as well. So combination product. Progesterone, and the problem with bioidenticals is we don't know if the progesterone is actually getting adequately absorbed, especially if it's a topical skin cream. So just be very aware of that. If they're on these treatments and on a progesterone cream, they might not be getting endometrial protection, so there's a real safety concern. They're manufactured in compounding pharmacies. They've got around the TGA by doing it this way. They're not approved for use, and your medico-legal indemnity is questionable if women have troubles on these. Often women will come to you because you're their first point of call. They trust you, they like you, they admire you and everything. And they say, I found this great stuff from the internet or this other practitioner. Can you monitor my safety on it? All right, so you've got to have alarm bells ringing. There is a great bioidentical hormone sheet from the Australasian Menopause Society. You can easily download that. There's a great one from the Jean Hales Foundation. So talk about it, talk about this slide, give them the sheet and just say, we're not doing it. We just need more study data, all right? It's probably a great way of giving hormones. We just need safety data. Some women have gone on to get endometrial cancer because they didn't have adequate progestogen for the endometrium, and one woman has died using these compounds. So you just need to keep an eye on that. It is expensive and the marketing is misleading. They say they'll titrate it according to their levels from salivary tests, which aren't very accurate. They say they sort of make it for the individual, and I don't know that that's exactly true. The important thing is to be up to date, which you are now, and to be well informed and to have lots of tissues in the room. There are lots of different websites. The Jean Hales website is fantastic, probably mostly for consumers, but also for doctors as well. The Australasian Menopause Society is also brilliant, and that's probably got more of a doctor focus. And there are 28 different information sheets specific to menopause, and you don't have to be a member to access those. So print them out, have them, give them out to patients if need be, but the Jean Hales ones are probably better for patients. And thank you for your attention. I'm sorry I was running late, and good luck with everything. All good. Thank you.